or what their thoughts were on that. But I'm not sure if that question is a question they'd be able to answer. So that's the one I wanted you to look at.
Gotcha. Hey, Hillary, can you hear us?
Yeah, can you hear me?
Yeah, how are you?
I'm good. How are you all?
Good. I don't think you've met Poonam before. This is Poonam Desai, a good friend of mine, ER doctor. And I think you were on the email this morning, Hillary. So Poonam is in New York, 6 weeks pregnant, and
Right.
got a positive test last night. So okay.
Right.
So what I may do, if it's okay with you all, I'll introduce you, Hillary, and then I'll say we've gotten a lot of questions from listeners. And then I'll introduce Poonam, and then I will ask you a few questions, and then let Poonam ask a few as well, if that's okay.
Yeah, that's great. That's great. And you don't care about the video because I have stuff that I'm looking at, and I assume that doesn't matter at all.
It doesn't matter. I am recording the video, but okay. I don't think anybody can really tell what you're looking at or anything.
Okay.
So do you go by Dr. Seger now?
I do.
Okay. All right. You didn't in residency, did you? It was.
No.
Okay. All right. Just making sure I don't call you the wrong doctor.
You're
name. Good. And for an introduction, yeah, I didn't know about your master's in public health stuff, which is really impressive. So right now, what is your official title, where you are, and what are you doing now, so I can introduce you in the best way possible?
Yeah. So let's see. It's funny. It's a small hospital, but I am the medical director of our obstetrics and midwifery service and our obstetric service line at Ashland Community Hospital.
Hey, Hillary.
Yeah.
Sorry, your audio isn't great. Do you know
it
what?
Isn't.
Can you? Well, it is when you're close like that. Yeah. So.
Okay, I'll come close.
And maybe if you go to the audio and video settings in your Skype.
Okay.
You click on the three dots to go to audio and video setting.
Yes.
Maybe increase the microphone settings a little higher.
Let's see. It's high. Do you want me to use my phone instead?
You sound pretty good now.
Okay.
I think it's just the distance. Yeah, that's perfect. So sorry about that. So you're the medical director for what is it officially?
It's Asante Physician Partners, Gynecology and Midwifery Services. People will laugh because a very tiny service.
Okay, so you're the medical director at your hospital in, what is it again?
Ashland, Oregon, and it's Asante Physician Partners at Ashland Community Hospital.
Okay, so is it fair for me to say the medical director for the OBGYN service at your hospital in Ashland, Oregon?
Yes, that's perfect.
Okay, all right, perfect. Okay, great. Dr. Seger, Dr. Desai, thank you so much for joining me. We've been getting a lot of questions about pregnancy and COVID-19. People are wondering about getting pregnant during this time. They're wondering about issues and risks around if they are pregnant. Dr. Seger is a close friend of mine. She's also the medical director for the OBGYN service at her hospital there in Ashland, Oregon. She also has a master's in public health from the University of Washington in epidemiology and maternal child health. So I really felt like you were the perfect person to ask these questions to, Dr. Seger. So I really appreciate your time. Dr. Desai is also a close friend. She happens to be an ER doctor in New York City in a very busy emergency department. And we had this podcast planned, and I got a really kind of disturbing to me email this morning from Dr. Desai. Poonam, do you want to just kind of tell your story, what's going on there in New York? The email I got from you this morning, it really kind of put me on my heels a little bit. I know you're 26 weeks pregnant, and in the email you mentioned that you had actually tested positive last night, which scared me, and so I can't imagine how you're feeling. So just tell me how things are going there in New York City, where you're on the front lines.
Yeah, so I'm an ER doctor in New York City, and I work at two of the largest hospital systems here. So I've been working back and forth between two ERs, helping them cover their shifts during this pandemic. And I've also been covering a lot of telemedicine calls for them. The ERs have been so crowded that we're not able to see all the patients we want to see. So on my days off, I've been covering telehealth, urgent care telehealth visits. In the last few weeks, we've seen an enormous increase in patients that are coming in with many of the symptoms of COVID, from diarrhea, fever, chills, shortness of breath. Our ERs here have been packed to the brim of patients that are severely short of breath, many of them requiring vent management, ICUs. Our healthcare workers are also very bombarded with all these patients, and not to mention all the exposure. And while I was seeing all these patients and working these shifts, it was definitely in the back of my family's, mind and my husband's mind that, hey, are you increasing your exposure? Is there a possibility you can also get COVID? During these shifts, when we first started, we didn't really know much about COVID. So a few weeks ago, a month ago, we weren't all wearing masks when we were working. It wasn't until recently that we were told that you should be wearing a surgical mask or an N95. And at some places we switched to a surgical mask. At others now we just wear N95s and goggles. So a few days ago, I started having symptoms where I woke up and I had some sputum, which never really happens. And it was blood tinged a couple of times that morning, which scared me. And I had also noticed that I had sore throat and a severe headache. And all three of those are symptoms I've never really had unless I feel like I'm getting the flu. And during COVID, I got a little more worried than normal. I called my boss and he said, come right in and we'll get you tested, especially because you're working so many shifts coming up in the upcoming week. So I got tested. Luckily, we were able to get the results pretty quickly. And last night I found out that my test did come back positive.
So I know you're a great physician. I know you've been taking all the precautions that you need to, and this has affected you. This is one of the big things that I've been really worried about is this spreads. If our healthcare workers on the front lines are affected, that's a bad situation for all of us. So you look like you're doing great. How are you feeling right now?
I feel good right now. I look back to all the shifts that I've worked and I keep thinking, was there something I could have done? Did I miss a time where, I wasn't wearing my N95, or maybe that sip of water I took, I shouldn't have taken it. And, you go through all the scenarios in the back of your mind. And while you're working an ER shift, every time you remove that mask, there's always, something in me that's like, should I be doing this right now? Is this water really necessary? Is this break really necessary? Because I know that I'm exposing myself and my baby while I'm working. And it's a thought that I think every single physician, healthcare worker that's working right now has when they are taking care of these patients, that what if I get this? What if I take this home?
Well, I want to talk to you a lot more about your experience, but I know you're going to be joining us for the virtual summit and you'll be able to tell us more and then answer some questions. But today we want to specifically talk to all the people who are in your situation. You're pregnant, you've been exposed, and I want to go through just a few questions that we've been sent. And Dr. Seger, I guess the first question that is on everybody's mind who is pregnant is, am I at increased risk of infection, of catching this virus? And am I at increased risk for complications related to COVID-19 if I do catch the virus?
Yeah, thanks. So as of right now, and essentially acting on the maybe 2 months of data that has had a chance to be published since the outbreak began, our best estimate is that there does not appear to be an increased risk relative to the rest of the population for maternal complications with COVID. And this is a really important question because in the previous coronavirus and respiratory infections like SARS and MERS, it appeared that pregnancy conferred a tremendously increased risk of pulmonary complications with those coronavirus infections. And that does not appear to be the case, but I think it's good to understand like the how robust our data is. And so there was a 9-case series that was published in the Lancet, maybe the first week of March. And again, that was 9 cases out of China. And none of those patients had developed severe pneumonia, and there were no maternal deaths. 2 of those patients, none of them had chronic disease at baseline, which I think is good to understand. One had preeclampsia diagnosed at around 30 weeks, and another had gestational hypertension diagnosed earlier. And so these are quite healthy patients outside of pregnancy, and they delivered at term. There were all the babies delivered and were vigorous, and there were no fetal infections documented. So this case series, I believe 6 of these couplets were tested, both amniotic fluid, cord blood, and the neonate's oral pharynx. All of that tested negative for COVID. And so it attempted to answer at least some of our questions. Does it appear that there is maternal to fetal transmission of COVID? And there's not evidence of that in that 9-case series. And they also tested breast milk, and there was no COVID positivity there. Now, all of them underwent C-sections, and 2 of them had fetal distress. And it's hard to tell. My understanding is that obstetric practice is probably really different culturally and in China from here. And I also think that, if you're in the setting of an outbreak and you have obstetric patients who are looking sick, you probably intervene earlier than you would otherwise. I think that many of these patients had CT findings of the interstitial pneumonia that we're seeing, but they did not have the severe respiratory distress and were not intubated in that. And so I think that is the most respected published data that we have. There was another case series of 38 cases that were published on the 17th of March that had a little bit more data and had some patients that were in different situations. Like there was someone who was at 30 weeks who developed, the mom developed respiratory distress and had a C-section for fetal distress. And I think that, this is really limited data. But I think the best news that we have is we are not seeing the extreme increased risk that we saw with SARS. And that is good. I think that the other thing is we are not seeing automatic neonatal infection with maternal infection, and these babies did well. I don't think we have really good data to speak to what happens when you get infected earlier in pregnancy, because honestly, this outbreak just began in December. And so those patients that were earlier on that experienced infection, we don't know what their long-term outcomes are. And that is why, our governing bodies have said, we don't see a really strong increased risk, but we would consider pregnant patients to be an at-risk population that we should be very careful about evaluating in the presence of symptoms and certainly in a positive test.
Hillary, you and I were both at the University of Utah during the H1N1 in 2009. I remember that pregnant patients were at really high risk then. So that's the first place that my mind went to with this pandemic, that was my concern. But it sounds like you're saying we really haven't seen it. It's limited data, but we're not seeing that in the data right now. Is that correct?
We are not seeing that. And you would assume that we would have seen that out of China by now.
Mm-hmm. But just in general, I mean, we're pregnant patients, correct?
Sorry, Matt, you kind of cut out there. I didn't hear that question.
Yeah, I said, but we still are in flu season and influenza in general, and those do kind of disproportionately affect pregnant patients usually, correct?
Certainly, certainly. And so that's one of the things that, you know, I would like to bring forward is that we know the outcomes of influenza and the maternal outcomes of influenza, and we know that vaccination is really, really important. Um, and you know, in the testing protocols for COVID, I think they likely vary by geography. And in my surroundings, if you test positive for flu, they actually don't go on and test you for COVID. And you know that, you know, I'm sure there's lots of debate about that. But you know, it's really important that the pregnant patients get tested for flu because there's treatments that makes a difference in their outcome. And in the case series of 9 out of China, one of those patients had co-infection with influenza. And so, you know, this is all just kind of coming together at the same time.
So the next question I think on every expectant mother's mind is, what about my baby? Is my baby at risk to have COVID-19? Is the virus going to be transmitted to the baby? Do we have any data on that?
Yeah, and so there were, so in that 9 case series, none of the babies developed COVID. The larger 38 case series, you know, I don't believe that there have been no documented cases of severe neonatal and COVID infection. But you know, we really have limited data, and I think that where this becomes a really relevant question is around what happens immediately after birth if you're delivering in the setting of if you have the symptoms and don't have a test back, or if you have tested positive, if you're delivering, do you have the baby with you? Do you breastfeed the baby? All of those questions. And so there's kind of differing guidance on this. And the CDC has recommended that you actually separate the mom and the baby, and that you can pump breast milk, and obviously use really good hand hygiene for pumping and that type of thing. And then when you bring mom and baby back together is kind of a case-by-case basis. The WHO guidelines and recommendations about this are more flexible, talking about, you know, breastfeeding and moms using masks and that type of thing. And all of these recommendations are coming based on really limited data. And, you know, I'm sure it's very regional depending on what the hospital's recommendations. I connected with our neonatologists here in Medford, and there's a lot of disagreement about this.
What about the actual, so that's kind of after you deliver, what about the actual labor and delivery? Is it going to be different? What is going to be different than would have happened several months earlier?
Yeah, and I think that's a great question. And I think this depends on what is probably going on around you in your geographic area. So for example, in New York, where I feel like the pandemic is, you know, really happening at this moment, there's probably potentially a lot of changes. One is that there's going to be less people in and out of your room. Two is that, you know, you probably want to talk to your provider, but you know, availability of the exact provider that you have might not be something that is guaranteed depending on what the need is around you. One of the most important things, though, is the visitor policies of most hospitals have changed drastically. And I would venture to say that nearly all hospitals will restrict visitors to one support person, which is, you know, either a partner or a designated other person, but often doesn't include a doula if someone has hired a doula. And so it depends on, that's a hospital specific thing, I would imagine. And so there's, it's important that obstetric providers are managing the expectations of their patients and explaining why, because this can be really difficult for people to come to terms with.
So less people in the room, probably separation pretty quickly, a little less contact with baby and mom. Let's go back even further to prenatal care. Are there going to be any differences in prenatal care because of COVID-19 or just being positive for the virus?
Yeah, so there's a lot of discussion and pretty clear recommendations that have been sent out this week about changing the frequency of prenatal visits for appropriate, low risk patients. And those recommendations have come out of both Michigan and Mass General, where they're proposing that you don't do the typical 11 to 12 visits, making contact with the potentially the hospital or other healthcare environments in a well pregnant patient. And it's important that people know that we have studied this, and we've documented that it's safe to do this as long as the appropriate risk factors have been taken into consideration, but also that people actually tend to be happier with their care when they get seen less and they're healthy. And so we've already studied this in for different reasons, but now we are going to use this more. And telehealth is also going to be part of this. Potentially not at the very end of pregnancy when we need to be, measuring how big the baby is and that type of thing. But there's established protocols that people are recommending. So people should not feel unsafe when these things are recommended.
Yeah, so you made a great point about differences in regional care. And so actually I'd asked Dr. Jeff Chamberlain if he was available to join us as well. So he's just joined the call, so I'm going to catch him up really quickly. Dr. Chamberlain is practicing in Steamboat Springs, Colorado. So Jeff, we just were talking about some of the differences in general. And so anything we say that's different in your hospital, we'd love to hear your experience. I know you had some cases today, so thanks for joining us coming from those. Hold on one second. I'm going to edit this. I'll edit this part out in a second. Hello? Thanks. So, Dr. Desai, I'd love if you have some questions for you to be able to ask. You made a great point, Hillary, about telemedicine. We're literally talking to 2 OBGYNs right now and getting advice, and the advice you're giving is great. So really do need to start using telemedicine more for some of these prenatal visits probably. So Dr. Desai, what's on your mind? What questions do you have?
I just wanted to add to what was just said. So here in New York, all my OB appointments have been transferred over to telehealth. And only the necessary tests are we going in for, whether it's a glucose test and the ultrasounds is what we're going in for. Also at my hospital, which is one of the bigger hospitals that I'm delivering at, we actually have no guests. So even my husband can't come in when I deliver, is what we were just notified recently. And prior to going up on the OB floor, they're going to be testing us for COVID before they let us go up there and deliver. And I'm not sure if you're COVID positive or not, how that's going to change where you deliver, but I know we're going to get tested for COVID prior to delivering. A few questions that I had, and I know many people who are pregnant and our healthcare workers are pregnant and worried about COVID are concerned about is if we have any pre-existing conditions like preeclampsia, does that put us at an increased risk if we are infected with COVID?
Yeah, I mean, I think, I mentioned that two of the seven cases that were in that case series, one had preeclampsia that was diagnosed at 30 weeks. And all these cases were delivering at 36 and a half weeks to 39 and a half weeks. And so one of those cases did develop, it had a diagnosis of preeclampsia that was being managed for, at least 6 weeks. And another had gestational hypertension. And in that case series, nobody had severe pneumonia or severe disease. And so I think that, as far as we know, we can't tell. As far as we know, we don't think there's a dramatic increased risk that we would have seen in a really small number of patients. One of the other things that has been brought up in the guidance is people who might have risk factors for preeclampsia who are taking aspirin. And that's a fairly common thing in pregnancy. And, all the discussion around use of NSAIDs in the setting of COVID, the question is, should we stop using the aspirin for prevention of pregnancy, preeclampsia, or should we stop using NSAIDs in the postpartum period? And ACOG, for what it's worth, has recommended that we continue the prevention of preeclampsia with aspirin because there's really good evidence for that. And we don't have the really robust documented evidence, certainly not in people who have already been diagnosed. I think the decision will be a difficult one if someone is diagnosed with COVID and is on aspirin. That's a different question, but I'm sure there's people out there wondering, should I continue my NSAID for these periods? And I don't think we have enough evidence to say everyone should stop it at this stage.
Okay, and that's reassuring in a way to know, and you do continue your aspirin, I guess, if you do have preeclampsia. So those are both good to know. Another question I had is that the Royal College of OB/GYN has advised their healthcare workers that if they're pregnant after 28 weeks to avoid direct contact with COVID patients, or direct contact with people who are point of interest or patients of interest. Do you believe that the CDC should adapt the same recommendations, or if we can, we should try to follow the same recommendations as healthcare workers?
Yeah, I think it's we're not going to know the best answers to these questions for a while. I think that ACOG has recently this week has said that pregnant healthcare workers should avoid the aerosolizing procedures. Because those are the highest risk exposures. And I think that it's really difficult because it's one thing to look at recommendations, and then it's another to be pregnant in the workforce and not be thinking about what it would be like.
Yeah.
And so, I definitely think this is a personal decision made on behalf of each pregnant healthcare worker. I don't think, my opinion is, and I would tell my pregnant ER docs, please don't intubate patients. If you're not in a single coverage ER and you have a partner who can do it, please don't do it. But I think that there are going to be some healthcare workers who the level of anxiety and concern about this is going to be so high that it's going to preclude them being an effective pregnant person and healthcare worker because you become both. And I just don't think we have the data to make a clear recommendation that everyone should either stop, or I definitely think that adherence to PPE should be something that pregnant people in the workforce should be very committed to.
Yeah, no, that makes complete sense. At our institution, actually, many of the institutions here, the anesthesiologists have taken over intubation. So that's one thing that I'm less stressed about.
Right.
Another question that we had is, if a woman tests positive, so for example, I already tested positive, would you recommend any prophylactic medications, whether it's azithromycin or hydroxychloroquine? Is there any studies on this yet?
So as far as what I was able to find is that there are studies on treatment, and there are, enormous calls for trials. But I would say that in the population, and they're certainly not on pregnant people, in the population at large, this is something I'm not as well versed in. But I would say that we definitely don't have the data in pregnant patients, and I think that I would argue that, and in the setting of admission of a pregnant patient for increasing respiratory distress, that's when those decisions will be made, probably in conjunction with a perinatologist. I personally don't think there's grounds for doing that yet in a COVID test positive pregnant patient who doesn't have signs that they're going to need to be admitted. But that would be something I would definitely defer to a perinatologist about. And I don't know if you have other thoughts.
So Hillary, I'm going to put you on the spot a little bit more and just get some clarification on that, because it's a question that we're all going to get. It's going to come up. The azithromycin and hydroxychloroquine, we've had a full podcast on that. We've talked about it a lot. If you listen to President Trump, or if you listen to Dr. Oz, who called the data jaw-dropping, a lot of people are going to be wanting this and asking this because they're worried. But it sounds like, I'll restate and you tell me if I'm hearing you right, you don't think someone who's asymptomatic or mild symptoms, because we don't have definitive data, not indicated in those patients, but only if someone gets much sicker, then in consultation with several other people, then you can kind of make the group decision. Is that what you're saying? Really kind of wait until it's a little more severe to try medications that aren't FDA approved and don't have big trials yet?
That is my bias at this stage. But I guess I think that, the data would be forthcoming, and I guess I don't know that there's data saying that if you take an asymptomatic patient and give them those medications, that they're not going to become severe in young, healthy female patients. I mean, there's a lot on our side as far as most pregnant patients are young, many are healthy, and then gender appears to also be a factor in all of this. And so that would be what I would tell my patients.
What about, I know we've had pregnant patients forever going into areas with malaria. Hydroxychloroquine is used prophylactically. How do you advise your patients that are going into an area where normally they would potentially take hydroxychloroquine for prophylaxis? In those patients, has hydroxychloroquine been shown to be safe in pregnancy, or how is it rated?
Well, we use it for lupus in pregnancy, and it reduces bad outcomes in that patient population. We use it in pregnancy, and so I don't think that's necessarily the issue. But I guess what I would say, and forgive me if I've been more concentrating honestly on the how we're caring for newborns and workflows and planning at our hospital. But if there is robust data for it preventing severe disease and otherwise really healthy young patients, then I don't think pregnant patients should be excluded from that. I'm just not aware of that data.
Sure. No, that makes sense. I mean, because there's several questions here. Number one is the safety of it. And so it's good to know that it has been used. So if we do trials and it shows there's a benefit, there is some safety record for hydroxychloroquine in pregnancy. And azithromycin, if these turn out to be effective, is azithromycin safe in pregnancy? Do you use it very often?
Yes.
Yeah.
Okay.
Yeah.
Okay.
Chloroquine can be used in pregnant patients, but usually we try to have patients avoid areas where they're going to be exposed to malaria first, and then, but if it's unavoidable, if they're going to that area, then it definitely crosses the placenta.
Okay.
Yeah, I mean, malaria is not a good thing in pregnancy, and that's what I was thinking as you were asking me that question. Don't go.
Gotcha. So, all right. It's good to know that if it does turn out in trials to be effective, that it could be an option for pregnant patients as well.
Yeah.
Dr. Saya, did you have more questions as well?
One last question, and this is probably the most important question for me, and it's, once a pregnant healthcare worker is confirmed COVID positive and has completely, healed and is asymptomatic and almost ready to go back to work, are there any studies of reinfection, and would a reinfection in a pregnant woman lead to possibly worse outcomes?
You made that question way harder than I thought you were going to make it.
So Dr. Desai, what I will say is we've had a couple podcasts on immunity post-infection, and just from a standard point of view, I'll tell you, Dr. Taylor Bright, our director of infectious disease, and Dr. David Sinclair, who's a PhD as well and really smart, both of them feel like there is probably going to be pretty good immunity. The data so far is showing good immunity. There's a question mark just because some coronaviruses we don't get great immunity from. There were a couple case reports out of China, people potentially getting reinfected, but there were question marks around testing for that. So not related to pregnancy, and I'll see if Dr. Chamberlain or Dr. Seger have anything to add. Not related to pregnancy. We think there is going to be immunity, but we're still gathering more data on that. I don't know if it's going to be different in pregnancy. You all could potentially speak to just the fact that in a pregnant patient, you have a foreign body there. I don't know if that affects your immunity to any other infection. Is there any, do you all have any thoughts on that?
Well, in general, pregnant women do develop immunity to infections to which they are exposed. And I don't think, my impression is that is not the question at hand here, is that if you get COVID now in March of 2020, and there's, a sustained epidemic or there's ongoing infections, and then you're exposed to potentially a slightly different COVID, which I'm sure would have a different name by convention next fall, would that immunity apply to the virus that is still circulating in the population at a later date? And that question is really hard to know. It's similar to the flu idea that you get immunized to, and pregnant women get immunized to this year's flu, and they still need next year's flu vaccine because it changes with time. And so that's not something that we have the answers to, but there is no evidence that being pregnant would make you not produce immunity like you would otherwise.
So you're still going to produce the same antibodies you would if you were not pregnant. Is that correct?
Yeah. I mean, that's what we see outside of COVID. And I think it would be hard to make the argument that it would be terribly different in this situation.
So there are a lot of people considering, before this happened, were considering getting pregnant. So they're still considering getting pregnant. Jeff, you made a really great FAQ, frequently asked questions document, and a PDF, and we'll share that on social media and at wildhealth.com. But I think one of the questions you had on there was that question: if you're considering getting pregnant, any recommendations either of you would give to patients who are still thinking about getting pregnant right now?
Well, yesterday I had a patient that came to our office that wanted to, in order from her reproductive endocrinologist, because we are out remote from Denver where her reproductive endocrinologist is, to have her to review the necessity of her appointment and exposing her and everybody and her ultrasound tech to this test. But she wants to get pregnant. She's healthy. She hasn't been exposed to COVID, and it's mid-cycle. We want to help her get pregnant if she wants to. And so that also, we ran the guideline. We looked at some recent guidelines by the American Reproductive Medicine Society. They said what they're saying is don't start new cycles right now, but you can finish a current cycle. And so that's a very specific case, but in general, I think there's going to be a lot of people that are stuck at home right now looking at each other and wondering if this is a good time to, grow their family. But they're also scared, and they're scared about the world that they're bringing their baby into, and if it's safe, and if they're going to remain healthy or not, and all the unknown, and also all the anxiety that goes along with being pregnant too. So I think it's a multifactorial question, and something that we could that I don't think it's a right or wrong answer. But if somebody's healthy and a couple is healthy and they're sequestered relatively well, then I don't have an absolute no to that.
Okay, so you're cutting out some, Jeff. Sorry. So, but you sent that FAQ. So just to restate what you said, the American Society for Reproductive Medicine, they recommend, number one, suspending initiation of new treatment cycles. So they're saying if you are trying to get pregnant, probably don't start a new cycle. But they said you could continue care for patients who are currently in cycle. That's the recommendation right now. They also recommend suspending elective surgeries, diagnostic procedures, and minimizing in-person interactions and increased utilization of telehealth. So I think those are good recommendations in general. Hillary, any other thoughts on people that are thinking about getting pregnant? Any words of advice or?
No, I think that this, kind of thinking back to the pediatrics podcast from the other night, like our supportive families and our supportive moms and dads and families in this time is probably one of the biggest takeaways, because we don't have the data on like the hard science about it, but we definitely know that pregnant people right now are really scared, and that that is something that we need to make an effort in our new changed ways of telehealth and connecting them with, and certainly in the postpartum period, we didn't talk too much about that, but connecting with people about, having a newborn in social isolation is something that is really something to think about, because people are already worried about their birth and the health of themselves and their baby, and then their usual social network that will help them through the postpartum time period, one of the highest risk time period for mental health issues in our lives, is going to be limited. And so how we support people through that time is going to be really critical, regardless of what we find out about all the nuances of treating severe COVID and that type of thing. Like that is going to be widespread, perhaps universal, in all of our patients who deliver in the next year or so.
Yeah, it's always a difficult decision as to when's the right time to bring another life into the world. And it sounds like there's a lot more to think about right now, but it ultimately comes down to a personal decision. So I know you all are three very busy physicians, a lot going on. So I appreciate you taking the time today. I think we're probably going to have a lot more questions after this podcast. So hopefully we'll be able to get you back on and ask more questions if that's okay with you.
Sounds good.
That'd be great. Thanks, Matt.
All right. Thanks.
Good to meet you.
Did you stop recording?
Not yet.
Hey,